Bharat, thank you. Thank you for joining us in Polls 2025. It's an honor to have an oncologist like you join us. So you can just walk us through your experience, doctor, like your interest in oncology, how it spiked up and how it's shifted today.
Thank you, Sandhya, first of all, having me here. And as an oncologist, it's a long journey of nearly 2 decades. And I have really seen the traditional era where we used to work hard in the ward to get the blood, the tissue, transfer to the laboratories. The simple microscope used to give us reports. It used to take a lot of time. And from there, the precision has started, first in lung cancer, before that in CML, a particular mutation, amplification started giving us hope that, no, even in stage 4, we can keep patients in longer remissions. In fact, those living beyond 5 or 10 years, I label them cure, right? And from there, the journey actually started precisely in lung cancer when I was doing, my DM fellowship at Tata Memorial Hospital. Then I moved into private sector, and subsequently the immunotherapy changed the face of cancer. And we really see, patients being cured with use of targeted therapies, immunotherapies, but it comes with a huge cost. Then I realized we need to have a biomarker which, we can screen the patients. Patient A should go to one treatment, patient B should go to B, whatever other treatment. If we categorize, then the cost effectiveness is much better, and the resources can be utilized in a better way. And I think the AI which is coming up and the genomics which are evolving with a lot of multiomics, the imaging playing a good role with AI supplementing to it. But at the end, we have to realize the clinician who is facing the patient has a tremendous responsibility. I have been saying it again and again, because the clinician has to no, they have to go to the lab and learn the nuances of what treatment or what diagnostics we are advising to the patient, because patient comes to us with hope, and they have to spend a good amount of money, but the results are brighter. But then which patient is getting good results, which patient is getting not so good outcomes, need to be categorized, and then it will become easier. So it's a multi-omics, which I say clinicomics, pathomics, radiomics, and attends your genomics, transcriptomics. Now there is epigenomics, and AI. I feel can look at all these things as a bird's eye view and can give us answer. I don't think we are there yet, but looking at the data which is coming up is very interesting. And a country like India, where we have 2 tier, 3 tier cities and rural areas, and with the kind of urban movement happening in the rural population, now every disease is going to know all the parts of the country, and where the high volume expertise are not available, be it a clinician, pathologist, radiologist, the AI is definitely going to be a game changer, where data can be transferred from anywhere in the world to a bigger laboratories, can be accessed by the high volume clinicians and the lab person, and there can be uniformity, and there needs a collaboration. And definitely it is going to help. What it will do, it will get down the cost tremendously, and we will reach out to larger proportion of patient, and the data can gather, and it will bring us to a good algorithm to what we want, which patient should be treated aggressively, which patient should not be treated aggressively, so that we get a good outcome.
Thank you so much,
Thank
Dr.
you,
Gulzar.
thank you,
Thank you
thank you,
so much.
thank you.
Just one last question. If there is one interesting case, which was like probably the pivot or the turning point for you to take up this precision oncology in a different way, if you could just walk us through that one.
So there are many cases to see. I have been working in the lab. I find it is very interesting. We should not only work in the clinic. I do work few hours, but I make sure that I learn bioinformatics from person like you, and apply it to somewhere. Because we do see a patient journey, how the patient is responding, and sometimes we get intuition that which patient is going to be with biomarker positive, negative. So I have this interesting chap who is 41-year-old, and I have presented this data in our conference which is going on, and it's one of the fantastic conference happened in India in last couple of years, especially with the newer data integrating with the clinical outcomes. So this case of metastatic RCC, and brought to me by his elderly father, and he was in stage 4 renal cancer, So we have prescribed him immunotherapy. After 2 cycles, the entire scan become clear. And he had a bad toxicity. Immunotherapy can activate your immune system, but it can backfire to your normal organs. So he developed bad hepatitis and which is immune related, and thyroiditis. And we had to stop the immunotherapy, and the treatment is steroids. So steroids, when we use to treat the toxicity, there can be a possibility that it can suppress the activated immunity and the tumor cells can come back. So with one cell, no, we tried when the PET scan was done, we did a circulating tumor cells and ctDNA for this patient, and both were negative. And subsequently, the patient was followed almost for 1 year, and the PET scan were clear. Subsequent time points, the CTC was not there, ctDNA was not there. It means the radiologically patient was in CR, and immunotherapy was stopped because we cannot re-challenge because patient had a bad toxicity. There is a possibility that you will restart and patient again land up into. So as per the guideline, we cannot restart. So with 2 doses of immunotherapy, now it's year gone, patient scans are clear. There are no circulating tumor cells in the blood. ctDNA in the blood, that is also absent. So now I can predict these are the good patients where I can actually in the future a research patient can be handled, that whether we can give only few cycles of immunotherapy to selected patients and de-escalate the cost as well as the toxicity of the therapy. So we have to track these patients subsequently. Obviously, this is not the end. You have to follow these patients. This kind of a research can be done in other set of patients. And in a country or like ours and many other countries which are low and middle income country, we need the answers for our questions. Not we can always rely on the Western countries' data. Our problems are different. Our resources are limited, and we have to have a patient specific and country specific solutions for this. And I think the genomic labs like US who are bringing down the cost by from $10,000 to less than $1,000. AI, which can be come and again brings down the cost, and image-based prediction of these biomarkers is going to change the future of Indian healthcare specifically. Next week, I am going to be a part of a conclave in Delhi, where pharmacogenomics precision is going to be discussed. How stakeholders can participate, because everybody cannot pay a cost of treatment. How we can get our research to each and every patient of our country or fellow countries who are not that into developed nations. I think developed nations are also looking at India for cost effective ways. So definitely I feel it is exciting time in oncology, and I feel privileged that I am a part of it. Yes. Thank you so much, Sandhya. Thank you.